All right, we'll go ahead and start over here on the left, please. Yes, ma'am.
For symptomatic pain control for genital herpes, do you guys have any recommendations? I've had a couple patients who have just come back over and over again, and I'm at a loss as to what might help them be comfortable enough to not come to visit me.
Yep.
There's no good answer.
Yeah, that's a tough one.
So topicals, as far as
Yeah, so
well,
topicals, I'll use a little bit. You got to be
burn
careful.
like a son of a gun. Though you can't use topical lidocaine. It burns like crazy. Sitz baths sometimes help. So like you would do for bad hemorrhoids. So sitz baths, cool, even cool compresses sometimes help rather than, and then systemic narcotics I think are really what you're stuck with because the primary genital herpes is miserable, absolutely miserable.
One thing I'll add sometimes if they, a lot of times there's a lot of complaint of this burning thing. So I find that you can add a little Benadryl or Pepsid, something like that. It actually works for their cutaneous burn symptoms. It may be enough potentiation with the opiates that you're giving to help them. It's obviously a really uncomfortable situation, but the mixture of topicals, a little bit of Benadryl, along with the opiates. This is one of the times where I'm actually writing for the Norco 10-325s. It really looks painful.
By the way, this is exactly the same problem you have with shingles in older people, things like that. There's a neuritis going on here, which is independent of exact location, which is very difficult for us to interact with. Some people are put on antidepressants as part of this.
Yeah, low-dose amitriptyline.
Amitriptyline, that sort of thing. And I would think that going with that, along with some low-dose narcotic, is perfectly reasonable. Lidocaine just doesn't cut this.
All right, very good. Over here on the right, sir.
Dr. Henry, I work in a level 4 ER, and I get the occasional TIA, CVA. And you had mentioned disposition with them. I have MRI once a week and no neurology backup, so it'd be either sending them home or transferring them out for an MRI.
You have no neurology backup.
Correct.
You are a fortunate man in many ways. If you have an MRI, available once a week?
Once a week.
Pretty much these days, if your initial evaluation, you've looked at the carotids, you've echoed the heart, you've looked at all those other sort of common causes, right. I think you might want to get them transferred for that study. I mean, I don't know what the crowd here thinks, but it's kind of become where we are in the standard of care. They would all be going on an aspirin at that point in time. By the way, if you look at the numbers, if you've had a TIA, your chances of stroking out, depending on whose numbers you look at here, could be 5% in the next 2 days.
And another 5% in the next 6 days.
Yeah.
In the next 6 days. This is Johnson's study from Northern California. And he did it and sort of looked at these things. Johnson did us all a favor by showing us the severity of this.
Actually, I'm not
illness.
sure he did anybody a favor because now we're all really in a bind.
Now we're in a bind.
And if you Google, TIA outcomes, what pops up are medical legal sites, not medical sites.
Right.
The attorneys are all over this. And
Call
what
Sokolov and Sokolov. If someone you love or someone you know
yeah.
had a bad outcome
It's
after having
crazy.
a brief mini stroke.
Right, and then the American Stroke Association just really drove the nail in the coffin by making TIA now a tissue-based diagnosis. It is no longer based on time. It's not even really based on symptoms, kinda. It's tissue-based. So now we're really stuck with this idea of having to image and something that's more sensitive like an MR. So we're really being painted into a corner when it comes to TIA. Now, if you were in Canada, they'd say, so what? Stick them on an aspirin, make sure there's nothing they can acutely fix today, and you're done. So part of this is our own weird medical legal climate here. The reality is they're getting an endarterectomy if it's really bad. If they're throwing emboli, they'll get some sort of anticoagulation. Otherwise, they're going on an aspirin. And this whole shenanigans about imaging has probably gotten a little crazy, but we're stuck right now.
We have
Remember
some
in
Canadians
Canada-
here, right? Canadians, is that right?
Well, in Canada, it's actually a TIA.
Hey. Right, yeah. The question is, in Canada, how you can tell they're brain damaged? I don't know.
Well, one of the issues from a medical legal point of view is if you go in to the recommendation of the Heart Association, They say all the TIA should be admitted to the hospital. Now, when you say when you admitted to the hospital, you got to be able to do something there. And so, if your hospital really can't do the workup kind of thing to find a treatable cause, then the most prudent thing to do is to send them where they can. Because to tell you the truth, if you had a choice between a heart attack and stroke, I'll take a heart attack, thank you very much, over a stroke. And so I think that it's a high-risk kind of game, and so I think we need to be relatively aggressive with it. Other people say, well, you know, if you can get all of these tests done by the next day, then that's okay too. And obviously they're all on aspirin, and so you have to be, I think, a little aggressive because of this issue of what happens if there's a stroke, and did you do what was reasonable to try to find a treatable cause? And it doesn't sound like you really have the wherewithal to do that where you are. It's called Darwinian triage.
Right. By the way, if you work them up in the emergency department, put them in your OBS unit, what percentage of those patients do you think they find something that they can actually fix or correct?
So the carotid ultrasound and the echo are very low yield.
Really low yield.
2 to 3%
Max.
we're talking about.
And I think that's optimistic. I think it's more like 1 to 2%.
Yeah.
Wow, okay.
Sorry, did we help you? No.
Yes, thank you.
I don't think we did. Go out and have a
sorry.
drink.
Yeah.
Move.
All right, we'll go over to the left. Yes, sir.
Good afternoon. When dealing with the shoulder exam or any orthopedic complaint, are we responsible for knowing and charting the eponyms or just the mechanism of how you tested it, like Yergeson's and Speeds and all that?
No, I think charting what you tested is adequate. You don't
Yep.
need to name everything in Adsons or in yeast or things like that. But they do shorten your charting if you do know them, so they're useful. And the same for the eponymous fractures. Naming every fracture, as I would say, is not really important to their outcomes. It does make it a lot easier to communicate with an orthopod to say, you know, I got a Colley's fracture, or I've got a Smith's or a Barton's. It helps. So I don't want to overstate their importance, but they do facilitate ease of communication.
Just curious, those orthopods can be a prickly bunch sometimes. Thank you.
All right, over here on the left, sir.
Thank you. Just a historical mention and a question. Regarding the medication-induced hypoglycemias, back a while we used to give diazoxide, which is Hyperstat, but instead of giving it rapidly, give it very slowly, and it blunted the rebound hypoglycemia. I don't think we have that available today as far as I know. But my question is, what about using glucagon to, get the gluconeogenesis from the liver?
You're talking about in oral hypoglycemic induced
Yeah.
hypoglycemia? It doesn't work very well.
That's the problem.
The mechanism that it works by, it doesn't work very well, and it's not sustained. But what is kind of cool is if you have somebody who has an a sulfonylurea overdose, or basically it's sulfonylurea-induced hypoglycemia, and you can't get their sugar. Think about what you're doing. They're on something that releases insulin. You give them sugar, that releases insulin. And it's taking every little molecule of glucose and shoving it back into cells. It's basically getting rid of it. So what you can do instead is give octreotide. So octreotide turns out to be a treatment for sulfonylurea-induced refractory hypoglycemia.
Yeah, if they have, at our place, if they drop their sugar a second time, in other words, they had a low sugar, we gave them something, we check it again in 2 hours, and they're back at 50, they go on an octreotide drip at that point.
Thank you.
Continue here on the left.
And my question regards the antibiotic treatment of pneumonia. So the nice chart that was put up had outpatient algorithms, but one question sometimes comes up is the issue of previous exposure. So if you have a patient who was in the hospital 4 weeks ago and now is back with pneumonia, is that changing your antibiotic pattern? And the other question which sometimes comes up is patients that are felt to be at higher risk for aspiration. So your elderly patient or something like that, does that ever enter into your antibiotic choices?
I can speak at our place. So we have a hospital-acquired pneumonia algorithm. It gets overused. What I find happening with our hospital-acquired pneumonia algorithm is, somebody comes to you and says, well, they drove by a hospital last week, so I started the hospital-acquired. No, they have to have been hospitalized. And then the question is, what's the interval? probably, I think it's hospitalized within a month.
30
is-
days.
Is what
Yeah.
ours is. So if they were hospitalized within a month, we go to the hospital-acquired pneumonia algorithm for drugs, and it is broader coverage.
But it's inpatient. So I
inpatient.
think the difference is, whether it's basically hospital-acquired exposure or not, is if they're well enough to go home, and that's by using the CURB 65 or the pneumonia severity index or whatever you have, and all of that gets kind of factored into those. If they're really well enough to go home, you still can send them home on the outpatient antibiotic list. It's that admission group that tends to be sicker,
Yeah.
and they're the group that has the bugs that are resistant that you have to be a little broader in your coverage for. So I think it still applies in somebody who is well enough to go home, to still be able to go home and on those same antibiotics. I don't
And
think it
her
changes.
sick algorithm, one of the main things you're worried about in the hospital-acquired pneumonias is Pseudomonas. And so that's covered in the sick pneumonia inpatient ICU list.
And they don't go home.
They don't go home. As for aspiration, I agree with you that this isn't really well addressed in a lot of the pneumonia algorithms. And obviously aspiration involves a bunch of oral flora and some different problems. We see quite a bit of it because we have as we like to say, we're a level 1 alcohol receiving facility, which involves a lot more vomiting than average, a little more homelessness than average, and a little more seizures than average, and a little more aspiration all around than average. If it looks like an aspiration pneumonia, either by x-ray because it's a right upper lobe pneumonia and things, we do tend to add Clinda to the mix.
And sorry, one more follow-up question. What about patients who come from the nursing home? Does that affect your choice? So a patient lives in a nursing home in terms of being healthcare associated or not?
It's factored into the pneumonia severity index itself. It gives you 10 extra points on that. So the odds are somebody from a nursing home with pneumonia is going to get admitted.
Right, they're old,
And
they
then
got
it is
10
a
extra points.
hospital-acquired protocol that you would give them in the hospital. So it's sort of, by default, ends up being a hospital-acquired. They almost all get admitted if they're from a nursing home with pneumonia. It's really rare, unless they're, the no recess, low recess kind of person, they would usually get admitted.
And if you look at people who came from a home situation where they were living, functional, that sort of thing, versus those who came from the nursing home situation, those people are going to do worse. They're sicker. This is a different group of people.
Thank you.
All right. Well, thank you all sorry.
I know many of you are not here, but I do want to get it clear that those discounts that you have for the video of this thing, that video won't be ready till the 1st of January because it has to be edited out. So
If there's a lot of editing for Billy's, they have to do a lot of
So
editing.
please don't.
Non-edited version. Want
No.
outtakes?
You don't get outtakes.
If you order before January 1st, you will be getting the old version of this, and so don't do that, please. So just wait if you're interested. Okay, we'll see you tomorrow then.
See you tomorrow.
morning.
Thanks for sticking around. Ciao.